The best method to analyze myocardial viability is studying myocardial perfusion with microbubbles. We have the largest experience with this method using our protocol with Adenosine Bolus, IV bolus. This protocol will be shown on a later talk. For now, suffice to say that Adenosine Bolus produce an important arteriolar dilation with enhancement of perfusion at the normal myocardium and a decreased perfusion at the ischemic myocardium due to coronary steal. Basically now, the microbubbles being smaller than the red blood cells, once injected in a peripheral vein will follow the circulation and the perfusion. The microbubbles go wherever the blood goes. Notice here that the myocardium does not capture the microbubbles. It indicates that the microcirculation is perfect and there is no structural myocardial lesion. Normally, we see this apical four chambers view, the IVS, apex, and lateral wall and papillary muscle. In the rest state, there is a small quantity of microbubbles already in these walls. Otherwise, they would be completely black. Now see what happens after an Adenosine Bolus IV injection. The walls almost disappear, since now they increase their contrast and are as white as the left ventricular cavity. When there is no ischemia and all regions have normal coronary reserve that responded with arteriolar dilation, an increase in blood flow in all microcirculation and hence more microbubbles in the capillaries of all walls with increased contrast. This is a normal perfusion with microbubbles using the IV Adenosine Bolus protocol. As explained before, we are using gated imaging. That's the reason for the intermittent view. Here, the IV septum, apex, and lateral wall. Pay attention to what will happen with the adenosine injection. Here it is. The heart almost disappears, since there was normal coronary reserve and arteriolar dilation, with increased perfusion of all the walls, and hence much more microbubbles in the walls. There is no ischemia. Important to understand that adenosine does not dilate large coronaries, only arterioles in the microcirculation. And how is ischemia on this exam in case of a viable myocardium? These patients have a perfect microcirculation with no structural lesion. The capillaries are normal, and since the ischemia area is using fully the coronary reserve, all the arterioles of the local microcirculation are dilated already. It has no further capability of dilation. At rest, there is a myocardial perfusion similar at the ischemic and the normal walls. Then microbubbles will come to the ischemic as well as the normal walls. After an adenosine bolus, the arterioles of the microcirculation at the ischemic wall will not dilate further, since it's already dilated. There is no coronary reserve in this region. The normal wall has coronary reserve and will respond to adenosine, immediately dilating the arterioles, and hence there will be coronary steal, and blood will be transferred from the ischemic toward the non-ischemic wall. And with the blood goes the microbubbles, and the normal wall will get brighter. The ischemic one will get darker. Simple as that. Look at this case. Pay attention to the left ventricle lateral wall. This is an off-X four chambers. IVS, apex, and lateral wall. At rest, there is perfusion here at the lateral wall and at the IVS, since they are not black. Microbubbles are in these walls at rest. Then we inject IV adenosine and watch what happens. See how it gets real black after adenosine indicating it's ischemic. See how the IV septum gets brighter. It's not ischemic. This is what ischemia looks like. A wall that was perfused initially at rest, since it was kind of gray due to a normal microbubbles quantity in the local microcirculation, and with adenosine became black. Now, what about non-viable myocardium? This situation happens basically for two reasons. Or it is necrotic, and as such, the capillaries are destroyed or clogged by white cells and debris. The remaining open capillaries are just a few, and so there will be not enough microbubbles in that wall, even at rest. Or it's fibrotic, a scar, also just with a few capillaries. Then, when we inject the microbubbles, the normal walls will show some brightness, even at rest, as explained. But the wall with non-viable myocardium will be dark, even at the rest, since there are few capillaries. Since darkness in a wall at rest may be just attenuation of the ultrasound, we inject adenosine that will turn the other normal walls brighter, but not the non-viable one that remains basically the same. The fact that the wall is dark or red at rest with no brightening during adenosine means that myocardium is not viable. Look at this example in a 4 chambers view. Here is the IVS, apex and lateral wall. Watch that the apex is dark even during rest, indicating no perfusion. It's a non-viable myocardium. After adenosine bolus injection, see how the lateral wall gets darker, indicating that it's ischemic, but viable, and the apex remains dark, as it was before, indicating non-viable myocardium. Here is an example. A woman with angina and 90% obstruction of the right coronary before angio-revascularization. Notice here this inferior wall with the same contrast intensity as the other wall. Then it's viable myocardium. After adenosine bolus, the inferior wall gets darker than it was a few seconds before, and the other wall is much brighter. Then this inferior wall is ischemic, but certainly viable. After angioplasty of the right coronary, see that before adenosine, there are microbubbles in every wall, and after adenosine, all the regions increase the contrast, including the inferior wall, showing that the right coronary angioplasty worked, and there is no more ischemia of the inferior wall. Thus, there is no doubt that echocardiogram has a very important place on the evaluation of myocardial viability.